is James Barbinsky. I'm the principal here at Massey College, and it's a pleasure to welcome you to this symposium. We have outstanding speakers who will be addressing the politicization, question of the politicization of healthcare. Before I take that question and introduce our panelists, let me just begin by acknowledging that we are on the traditional territory of many Indigenous First Nations, and these include the Mississaugas of the Credit, which are actually treaty holders for this territory, the Anishinaabe Nation, the Chippewa, the Haudenosaunee, and the Wendat peoples, and that this is also the territory of many other Indigenous nations, First Nations, Inuit, and Métis, people from across Turtle Island, and we're very grateful. I personally am very grateful, and we, I hope, are grateful to have the opportunity to share, to care for, and to work peaceably on this land. And those values are very much values of most especially the Mississaugas of the Credit and of other Indigenous nations. And with that acknowledgement, let me just say it's a real pleasure to open this workshop or this dialogue on politicization of healthcare. That is a loaded question, I have to say. One of the great political philosophers of our time asked or defined politics in a very simple operational way. That politics is about fundamentally who gets what, when, and how. And so the very question of the politicization of healthcare delivery, access to healthcare delivery cannot be, although it is fundamentally a political question about who gets access to what, when, how, and under what rationale. So I'm very excited and very interested to hear the dialogue and the commentaries from each of our speakers, who are some of the most formidable and accomplished leaders in thinking about and in delivering the infrastructure, the institutional infrastructure, the operational infrastructure for actual healthcare systems in our country, and have thought and contributed to dialogue, to debate, and to understanding about how to approach the question who has access to healthcare, when, and under what circumstances that I just outlined. The concept itself has the concept of the politicization of healthcare has many interpretations, and it still is imbued with a great deal of ambiguity. And so this afternoon, I'm very eager to listen to explanations around how politics and political philosophy and political practice, how this actually shapes, influences, and reshapes the organization of healthcare and how it is actually delivered. And then finally, how the public sees that relative to their expectations. David Miller, without a time, David is one of Canada's most preeminent leaders in health and healthcare. He's also a leader in so many other fronts. He's a Canadian physician, a medical researcher, and a former president here at the University of Toronto. He's a ISIS scientist emeritus and a founding chief executive officer. He was inducted into the Canadian Medical Hall of Fame just a few short years ago. He's a Rhodes Scholar. He completed his MD training here at the University of Toronto, went on to Oxford, where he earned his doctorate in philosophy, in 1983. And he has completed work and a residency and has worked in internal medicine and clinical epidemiology for most of his career, in fact. He developed the proposal for the for ISIS, not that ISIS, but one I'm about to describe, for the Institute for Clinical Palliative Sciences. He developed this proposal in 1991 and served as the Institute's president and inaugural chief executive officer from its inception in 1992 through to 1998. And I can say in my own medical career, during that period, and then post facto and all the way through to today, ISIS has had an enormous impact in terms of how we think and understand healthcare and healthcare delivery, how we measure, evaluate, and so on, our healthcare system. And that really is rooted in the founding moment or the founding period of ISIS. That requires absolute clarity, absolute determination and focus in terms of leadership, to setting of priorities, and those characters very much have defined David's career. Founder of ISIS, president of major commissioner, or the chief commissioner on a major report on research funding in Canada and how that might be reshaped, and so on. So I will just, I could go on, but David is truly an extraordinary leader and not afraid to be clear about his particular view at any particular time. The second speaker who will be joining us online is a dear friend. David's a friend too. Our second speaker is is a very dear friend. It's Carolyn Bennett. She is a family physician, has been a family physician for more than 20 years. She knows the front face of clinical medicine, both in the family doctor's office, but also in hospital, delivering babies, looking after patients in the emergency room, stewarding them through the hospital, direct patient care in the hospital. She really understands very, very materially and intuitively what it is to be a clinical practicing physician. She's also today, fast forward, she's now ambassador ambassador to the Kingdom of Denmark and a retired politician. Some years ago, she became a member of the Liberal Party. She represented the Toronto-St. Paul region in the House of Commons from 1997 all the way through to 2024, so a 27-year history as a politician. She was a cabinet minister in the governments of Paul Martin and also Justin Trudeau. She was Minister of State for Public Health, Minister of Crown for Indigenous Relations, and Minister of Mental Health and Addictions. As I just mentioned, she's currently the ambassador to Canada, the ambassador of Canada to the Kingdom of Denmark. Carolyn really is an extraordinary political leader. Probably one of her, at least in my estimation, one of her greatest assets is that before she speaks, she actually listens and really tries to understand what are the currents, what are at play, what are the issues at play. And at that point, she doesn't just speak without a deep understanding of the political structures, first the political concerns, then the political structures that influence those concerns, and an understanding of how to reshape those so that genuine issues and genuine concerns can be addressed. So Carolyn, welcome, and I'm looking forward to listening to your thoughts and comments. And our third panelist is a new friend who I've just met today, and his name is Mr. Anthony Dale, and he served as president and CEO of the Ontario Hospital Association since 2013. Over his tenure, it has been a very, very challenging period from the time that he started. Over his tenure, he's led the organization through a transformative process that has really strengthened its impact. It created new services for the Ontario Hospital Association and increasing the value of those services for specific Ontario hospitals. One of the greatest challenges since he became CEO
obviously has been COVID. And you can well imagine the challenges that he faced as CEO of the Ontario Hospital Association during COVID. He led the OHA's effort to support the hospital sector and individual hospitals in the face of really one of the most serious health crises and civil emergencies in our province's history. Under his leadership for more than 10 years, OHA member satisfaction scores have increased enormously. And that speaks to not just good leadership, but to effective leadership. And in addition, Anthony currently serves as chair of the board of trustees for the Healthcare of Ontario Pension Plan. And he was appointed a senior fellow at the Institute of Health Policy and Management Evaluation here at the University of Toronto's Dalla Lana School of Public Health. And he's previously served as an aide to the Premier of Ontario and Ministers of Health and Long-Term Care in a range of senior advisory staff positions. He has a wealth of experience, both in the hospital association sector and in government. And we're very, very happy and really delighted that you've joined us, Anthony, and look forward very much to listening to your comments and to the dialogue that follows. And with that, I am going to ask that as you speak, think about this question: who gets what, when, how, and why? It's really a fundamental and operationally defined conception of the political process. And with that, I'm going to introduce our junior fellow, who has really worked incredibly hard over the last few months to pull this panel together. Senthujan is a PhD student in public health policy and has a really, in my view, after spending a lot of time talking with him over the last few months, has a very clear mind and ability to focus on viable and some of the most pressing issues of our time. He's asked that I not give a detailed introduction, and so with that non-detailed introduction, I will pass it over to you, Seth. Thank you very much.
Thank you very much, Principal Urbanski. All right, to level set with the audience. Healthcare is often framed as a technical system. Hospitals, policies, funding, staffing are all interconnected to shape and deliver care at scale. But peel back any layer of that system and you'll find politics. As Principal Urbanski mentioned, who gets care, who decides, who's heard, who's invisible, and most importantly, who holds power. The boundaries between policymaking, political ideology, and healthcare delivery are collapsing, maybe. Before we dive into discussion, dialogue, and hopefully debate, I want to begin by asking each of our panelists to share their own perspective. When you hear the phrase, the politicization of healthcare, what does it mean to you? Not just in theory, but in your lived experience as a leader. This question is not about arriving at a single definition, not at all, but about surfacing the multiple ways politics show up in health, overtly and subtly, and how each of you have encountered that in your own reality. So with that being said, Ambassador Bennett, may I start with you?
And thank you, and thank Dr. Obinsky for the land acknowledgement and for how we all still value so much of what he did and why this question is so important to him in terms of what that meant to him in Rwanda and what it means to everybody in emergency departments all across the country. But I have to say that politicization can be a good thing. It means we really need the people to understand and be able to be immunized against the mis and disinformation that there is now, and having accidentally ended up in politics because of the fight for the women's hospital, where women were really clear what they wanted and what they didn't want, that we actually, they understood doctor to interdisciplinary, they understood hospital to community, they understood that they should be the boss of what was happening to their bodies. And out of that came the understanding of social determinants: poverty, violence, the environment, shelter, equity, education. How do you turn down the demand side in order for us to have a sustainable system? So I think we need much better education. And I think, as Dr. Naylor helped me as we set up the public health agency, where my mantra was putting the public back into public health, so we would get to do the stuff that mattered and stop doing this stuff and stop paying for the stuff that doesn't work. And that means ISIS and evidence is everything. And if patients and citizens understood the evidence, they would understand why we have to change a rural hospital into a healthcare center that stabilizes. They'd understand we don't want antibiotics for colds, and that we really have to do a much better job in getting the patients and the citizens educated.
Thank you. Mr. Dale?
Thank you. It's great to be here. I look at the question you've asked in two ways. The first point around politicization for me really means how healthcare is becoming embroiled in the culture wars that are leaking north from the United States in particular. And this primarily affects medicine and science and how society thinks about important things like vaccination and masking and pandemic responses and a whole host of other very important matters. But there's also one that I have a longer term experience with, and that is in the political culture of dialogue, discussion, and debate and decision making about healthcare in Ontario in particular, which is where I've spent my career so far. We have a publicly administered healthcare system that's led ultimately in a Westminster style of government. We have an elected premier, we have a health minister. It mimics very much the United Kingdom, which is of course where our parliamentary system came from. The king is here today. You can see those important institutions at work today. So of course you're going to have politics, because that's what Parliament is ultimately all about. It's how we make decisions, who gets what and when. But what I have observed is, I would say, a deepening and ever more acute political culture of decision-making setting in when it comes to healthcare in Ontario, and that's being driven by social trends that are accelerating. So the ability of our province to maintain a consensus over policy and objectives for our healthcare system is completely breaking down in the face of social media and the tribalism that comes along with it. The trajectory for debate and discussion is basically driven by issue management and what's important in the news during the day rather than what's important over the long run. You have institutions that are have critical roles in our parliamentary system, like the Auditor General and the Ombudsman, Ombudsperson, providing a deep critical analysis of political leadership on a daily basis. And that has essentially caused a massive centralization of decision making, because all 16 people in the province of Ontario, if you ask them today, probably think that the Minister of Health is personally responsible for what goes on in our healthcare system. And what we're now in is a vicious cycle where we're finding it very difficult to break out of it. And the debate about healthcare is starting to mimic the adversarial debate on the floor of question period, where there's one side or the other. There's a right side or the wrong side. And it's creating a culture of victimization about our healthcare system. And that victimization is focused on the concept of resiliency, the concept that the healthcare system has to be protected, that it's got to be sustained. And that is coming at the expense of that healthcare system being able to adapt. And I encourage everyone, if you are interested, to read Alistair Roberts' recent book, Canada, the Adaptable Country, How We Can Survive the 21st Century, because unless we learn to change our politics and the way we make decisions about our healthcare system, we are in for a very, very challenging future.
Thank you. And Dr. Naylor?
Thanks very much. Great privilege to be here and to share the panel with Anthony Dale and Carolyn Bennett. Thank you, Mr. Principal, for the overgenerous introduction. I'm glad that you conflated serendipity and competence. If I think back about 40 years ago, it was a very boring Oxford thesis that was turned into a book. And the subtitle of the book was Canadian Medicine and the Politics of Health Insurance, 1911 to 1966. And that reminds me, since I did that a long time ago, that medicine has always had a hugely political side to it. And as others have said, politicization is baked into this process. As soon as you have the state involved, and it has been for a very long time, going back to Bismarck and before that with early public health measures, you will have all these questions arise that become very political. I agree with Dr. Bennett, who said sometimes politicization can be a good thing. And if you think back historically, when Medicare was being introduced, those on the right said we were politicizing healthcare. Now, when anyone talks about trying to introduce private-public partnerships, the left says we're politicizing healthcare. So it's also a rhetorical gambit. So I think it's very important to focus on policy making. And that's where the process issues that Anthony has raised come into play very strongly. We've seen centralization of power with multiple prime ministers and premiers. This is not purely ideological. Left and right are doing it. And this process of disenfranchisement of the caucus, the disempowerment of ministers, is a real worry because it concentrates decision-making. And it means that everything's driven around issues management, and what you lose then is the long-term. For healthcare to function, you have to have a long-term view. You can't do what we do now in Ontario. Dealt with this filling in as CEO at Sick Kids, and I've heard about it from Anthony and others. Hospitals don't even get their budgetary allocations till after the fiscal year is over. So just one indicator. So I think there's some real issues to be joined about policymaking and the process, and some of that is getting contaminated by the culture wars we see south of the border. It's a troubling time, and I'm glad we're here to talk about it.
Thank you very much. And as you can see, all three of our panelists have somewhat different definitions on how they consider the politicization of healthcare, but there are quite some synergies. So let's talk about topic number one, the political determinants of health. So these are government, voting, and policy, power structures that shape how we consider healthcare. So my first question is specifically for Dr. Naylor and Ambassador Bennett to weigh in on, is in Canada, we like to talk about health as a shared responsibility between federal and provincial governments. But some may say in practice that sharing often looks more like passing the buck. So my question is, should health be treated as a constitutionally shared but functionally federal priority? Does our 10 health systems mantra still work today? Do we need more unitary federal mechanisms? So I'll let Dr. Naylor weigh on this first, and then I'll let Ambassador Bennett say what she thinks.
That's not exactly an easy issue to weigh in on, but I'll have a go. First off, we have to understand that under the Constitution, rightly or wrongly, as with many things, we have a division of powers that places health squarely with the provinces. Public health shared to some extent, but the operating arm of healthcare is provincial. Second reality, Ottawa has moral authority here as the entity that really scaled Medicare and hospital insurance before then into a national policy with cost sharing. But the real core competence in delivering healthcare lies with all kinds of people on the front lines, and of course, the policymakers at the provincial level. And that experience and competence varies from one government to the next, between ministers and administrations. So it's an uneven playing field, and it's a concern. I would say that the rhetoric of the federal government as a safeguarder of Medicare wears a little thin when you look at the history of cost sharing. And in 2015, a panel I was fortunate to chair actually argued for a different way of doing business, a sort of shared model where the federal government would continue to do cost sharing. It might sustain the Canada Health Act with some penalties. But rather than that sort of parenting role, I'll take away your allowance if you misbehave, Junior. It would be a sharing facilitative role to identify, evaluate, and scale innovation. The federal government would put $1 billion or more on the table over time, and each province would participate as it saw fit. Institutions could participate as they saw fit, so-called leapfrog federalism. But we would actually finally start to look at what is working and not working across Canada in a pluralistic way. Maybe even look at some parts of the US that work better than anything we do here, believe it or not, such as their integrated delivery systems, and then begin to incorporate them into our fabric. So I favor, a collaborative growing up relationship, not this parent-child thing. And as long as you have that, the provinces will continue to squawk for more allowance every chance they get. And I really think if we start to talk with each other across the nation as adults, the Federation works better. I'd like to see us head that direction. There were some hints of that in about 2017. I think Carolyn Bennett would agree. We saw a little of that emerging, and it sort of disappeared, unfortunately.
Ambassador Bennett?
Yes, I think we go where David left off in terms of health versus healthcare. Healthcare is clearly, the delivery is provincial, the health of Canadians is shared. And we learned that germs don't respect borders. We've learned it around the what we are trying to do with national licensure of health professionals, that we actually need an approach. My concern has always been that certainly as Minister of Mental Health and Addictions, that some of the populations with the worst health outcomes are a federal responsibility. And so that means Indigenous, it means the armed forces, the veterans, corrections, the RCMP, and even some aspects of the public service. So where we really don't have the moral authority to tell anybody what to do when our outcomes are the worst, but we do have a responsibility to share the data in a real way. And I think that we learned, I think, David, during the 2004 Accord, that when each of the provinces measured their data differently, patients couldn't decide that BC was doing way better on cancer care, or that other areas. So that if you're going to give, if it's going to be political, then the citizens have to have the data to say, how come they're doing better on this, or the wait time here is longer, and are we even measuring the wait time at the right moment when the family doctor knows this person needs surgery, and how do we actually get this back? So I sort of think it is about transparency and accountability, but I also think that we can't be so, here in Denmark, I mean, I don't think the public-private partnerships are not a swear word, and that there are things that if governments and the private sector can work together on, whether it's lab work, as Monique Bejean was saying, or whether it's housing, or whether it's all of these things, that we actually have really not innovated in the way, because of a certain misunderstanding, as was said at the beginning, of terms of what's left and right.
Thank you. Mr. Dale, voters care about healthcare, as you can clearly see by the audience here and myself, although some of us may be a little bit more biased. And I would say that healthcare is one of the most pressing issues in our nation today. And you run one of the largest hospital associations in this nation.
The only one.
The only one, exactly. So my question to you is, how well do they actually understand, and by they I mean voters, actually understand who's accountable for what? And do you feel like catchphrases, slogans are replacing substance at the ballot box? I do want Ambassador Bennett to weigh in on this after Mr. Dale.
I mean, it depends on the times. I mean, you can have political parties that embrace the policy responsibilities that they have when it comes to healthcare. But in general, over time, we've seen political parties, because of a complete uncertainty about how to carry forward, what policies to implement, what changes to make, that you're right, that they do reduce their agendas to kind of simple sound bites and slogans. You know, at the end of the day, this boils down to political courage. And when you're the average person, the average voter, and you're in an emergency department, and you can't get access to care, your child can't get access to care in a timely fashion, you want to know who's responsible. And to me, this gets back to what I tried to express at the beginning. The Minister of Health is the most senior elected official in our province and is accountable for the health system, but there are accountabilities across our health system, and those responsibilities, rather than being centralized, need to be decentralized back into the hands of the governors and management and clinicians who are most ideally suited to performing those duties. So, in reference to your question to the other panelists just a moment ago, the answer is not more centralization, it's actually decentralization. And it's a role definition by governments at the federal level. For example, I agree completely with Dr. Naylor. Our federal government should be wholeheartedly focused on fostering clinical and technological innovation in the face of the most astonishing demographic wave of chronic disease that our society will ever see. We're already on the journey now. By the year 2040, the number of people with multiple chronic conditions in this province will be mind-boggling. Our current system is absolutely poorly designed to prevent that chronic disease, let alone care for it should it all come to fruition over the next 15 years. Our provincial system absolutely needs to be reconfigured to reduce reliance on highly costly acute care systems, but create more integrated systems as a replacement. And this is where we are constantly stalled. So to my mind, the average voter needs to understand where hope and the future actually lies, and ideally more political parties would be honest and brave in that responsibility. When I was a staff person in the Harris government in the 1999 general election, after a very tumultuous period involving the Health Services Restructuring Commission, there was one day of commitments on health policy. And the health policy was a strong economy equals strong healthcare. And that's often where the debate can get boiled down to and distilled at its essence. In that instance, there was a meaning behind it, but to the point you're driving at, how much hope does that really lead the average voter when it comes to what they see in the emergency department when they need care or their child needs care?
Amazing, thank you. And Ambassador Bennett?
Well, yes, I mean, here in Denmark, actually, critical thinking is taught in school. Health literacy is taught in school. People are learning how to decide what's a good study, what's a bad study, and what they thought they wanted, but what they need. And so I think we have to talk to the people in Emerge. What are the, and right at the moment where the people don't have a family doctor, but we have to build the alternatives that to know that you're going to wait 12 hours if you go to the emergency department is unacceptable, but maybe you would rethink whether you needed to be in the emergency department and whether other things and other advice can actually satisfy and be better care than being in Emerge. And so I just think we have to, it is the health literacy thing. It is data in real time as to what's going on. And it is the choose wisely, helping voters and patients make good decisions. But we can't be telling them where we stand in the world or where we are on this if they have a sick parent that they can't get care for or see a specialist or those sorts of things. So it's going to be, and I mean, Nova Scotia, they just won an election on healthcare. So it's going to be political, but we have to have informed voters who happen to be patients, and women are the healthcare guardians of their families. And you're going to have to, if you're going to appeal to the woman's vote, you better fix healthcare.
Thank you. So to round off this topic, a question for all our panelists. What would it take to move from fractured responsibility to the structural innovation that you're looking for? And can evidence survive in a system that's increasingly shaped by ideology, polarization, and disinformation? I know it's a heavy question, but we are tight on time, so let's try to keep this one brief, the answer to it. I'll pass it on to Dr. Naylor first.
It's pretty clear what would work in an ideal world, and that is, instead of having doctors operating in this sort of pushcart vendor model, which is protected now by arbitration in multiple provinces, a real issue, You would have much more of a team-based approach. You would have accountability through an organization that would have lay board of directors along with some professionals. And that integrated organization would cover community care. It would cover the relevant social services. It would cover drugs in the same envelope rather than having a separate silo to burn money. It would have docs and nurses, primary care nurses and others. They'd all be under one roof. And you'd have a budget per patient adjusted for severity of the patient and social needs. And that is what would be a Canadian-style integrated delivery system, such as we see in the US. We've been so busy sneering at the US, with increasing justification, I might add, that we have not paid attention to the lessons to be learned from the 3 or 4 outstanding integrated systems they run there. And if we could import those holus bolus, we'd be so much better off. I just want to close on this front by pointing out that all this will take political courage and willingness on the part of anyone in power to face down some very strong vested interests. The other thing that it will take is letting go, and on the one hand, and squeezing a little bit on the other. Let go of hospitals. When I was filling in as CEO of Sick Kids Hospital, I was startled by the extent to which the provincial government was involved compared to being president of the University of Toronto. It's suffocating. So you give some freedom to operate there, but you also bring people in my profession closer to these organizational structures, so you align incentives, and we get innovation and great patient outcomes and great patient experience, all measured, looked after in the same grouping. 5 or 6 of those organizations, make it 7 or 8 if you want to account for regional differences and demographics, would transform healthcare in this province.
Mr. Dale?
So political debate about healthcare in our province is fostering on this notion of protecting, right? We have to protect what we've got. We have to make it sustainable. It's vulnerable. It needs support. It needs more resources. That's what I mean about the concept of resilience. We're focused so overwhelmingly on trying to make the existing system resilient, and the debate in the legislature and on the campaign trail focuses on that binary situation. You know, you want to do this, well, it's under attack. I have to protect it. Change is bad. And that to me is the fundamental dynamic that has to be broken if we're to advance forward with the kinds of change that Dr. Naylor and Dr. Bennett are talking about, which is very significant rethink of our healthcare system in the face of this demographic challenge that is already on us. Again, there will not be enough healthcare workers to hire if we keep up with the existing model of care. You already have the largest workforce in the entire province works in healthcare. Hospitals are one of the largest employers in healthcare. As the population ages into retirement, the size of the workforce will shrink relative to that population, and most of our growth will come from immigration. So you tell me how we can keep fostering and maintaining this existing system, this very proud system filled with people who are incredibly dedicated to the mission of serving the people of Ontario, but who are also desperate for profound change, and the change that fundamentally has to be founded on the concept of decentralization of responsibility.
Thank you. And Ambassador Bennett?
Yeah, I think I was at Queen's Park in the early mid-90s with Dr. Marlowe, and we were testifying that our team-based care approach was what people needed, where you actually could have the most appropriate care by the most appropriate provider at the most appropriate time in the most appropriate place. And so we need to be able to persuade people what's appropriate, and we still hear people, but I didn't get to see the doctor. Well, the doctor, or I didn't get to see a psychiatrist. We have to educate patients that might not be the best person to see, and or that they all communicate with one another, and that you are getting the best care because of the team. And so I think it is going to be, we've lost. What we understand from the College of Family Physicians, we've lost a couple of generations of people not choosing family medicine because we didn't change to team-based care, and so we actually need people to want to be family doctors and know that they'll be backed up with a really great interdisciplinary team.
All right, Mr. Dale and then Dr. Naylor.
So if you look at a slide, for example, that details every single state-sponsored integrated care initiative introduced in this province since the 90s, you run out of space. There must be more than 20 of them. And almost none of them have any durability or continuity. Each one is either a failed project, is dismissed by the new government because it was an initiative of the previous government. And what do all of those models have in common? They're highly, highly centralized. Some of them, even though their very design feature is to actively decentralize and integrate, the gravitational pull of the system of politics in our province is such that they can never be decentralized because the state won't allow it at the end of the day. And it's not the people, but it's the very structure of the system itself. And that is very, very challenging to change, especially at this late hour. But the real answer lies in integrated care done on a local, regional basis with independent governance and responsibility for the full basket of services relevant in that community, as well as the funding levers to make it happen.
Dr. Naylor.
I'd second what Dr. Bennett and Mr. Dale have said completely, but I just want to touch on primary care reform and the issue of family physicians. I've seen this movie a few times. This was done in the 90s. I was one of the group advising the Martin government on the Fix for a Generation, and primary care reform was baked into that health accord. Made a little progress, and then it just was allowed to slide back again. Fast forward a few years, and we had a lot more interest in family health teams, alternative ways of compensating family docs. That started to get momentum in 3 provinces, Alberta, BC, and Ontario. And then it turned out that a tiny minority of family physicians were really, if you will, abusing the system by not being very accessible. And instead of holding them to account and saying, pull up your socks, government started to retreat. It's the same thing. And that, you go to 2015, I was involved as mediator of the negotiations between the OMA and the government. We had very good residency matching back then, but that was the last of the period in which there was still family health teams and these team-based care models. As soon as they disappeared, and also incomes began to erode, we lost this generation of family docs. Add in the pandemic and the burnout, and it's a real crisis, but there's a catch here, and I'm gonna close on this. We can train thousands of family physicians, smart new young people, nice diverse workforce to go out there and help people right across the province. But if they can't get access to a specialist, sending their faxes, and yes, it's gonna be a fax, I'm sorry to say we have to stop that too. But if they can't get access to a specialist, can't even get a reply when they refer someone, how long are they gonna be staying with it before they burn out? So my worry right now is we're doing a bit of a one-hand clapping exercise. We're beating on hospitals, saying you've got to be more resilient, cut your budgets. And we're investing in primary care reform without a plan for how to bring these sectors together and link them to the social services side and the community so we get action on the determinants of health in a coordinated way. So even the reform that's underway, much as I admire it, and I think it's so important to support family medicine, I think it's doomed to fail the way it's been set up.
Interesting insights.
Maybe I would just like to say that what Dr. Naylor is describing is what we actually had at Women's College, because the specialist would call us back because we knew we didn't send them stupid stuff. And so it was interesting. What we would send to the specialist would be interesting to them. And so when you've got a community of specialists that and a relationship with them, then you can get through the system, but not if it's faceless bureaucracies and fax machines and no trust as to what it's all about, what the family doctor missed, or all of it. It is a lack of respect that really puts the residents off, and the fact that in medical schools people are only trained by in the lower years just by specialists instead of by great great family doctors. Like I think I heard Dr. Marmorio just laugh out loud, but it's a it, it's a family that you actually need to be able to look after communities and to be able for patients to know that they and we have to have the nerve to say you don't need to see a specialist. We're going to see what's happening, and so just ridiculous referrals is also part of what I'm afraid to say that here in Denmark the family doctors don't really have a comprehensive practice and tend to be referring much more than I'm used to.
All right, thank you very much. We have to go on to our second topic, which is the mental health transfer. So I do want to level set with the audience. I'm not interested in relitigating what happened, what went wrong, any supposed failures of the mental health transfer. What I'm more interested in understanding that currently in Canada, suicide is the second leading cause of death among youth and young adults. Men my age are approximately 3 times more higher to commit suicide than women. Canada remains one of the only 2 G7 countries without a national suicide prevention strategy. And we have the second highest opioid death rate after the US. I lied, it's the third. Scotland just beat us. So, with all of these concerns, why don't we have an earmarked transfer for mental health services? I know the original proposition has been diluted, has been called under different names politically. I'm interested in understanding. I know we have a lot of mental health professionals in the audience today. Why is there not enough sustainable funding being allocated for mental health services and substance use issues here in Canada? Dr. Naylor?
Yeah, this is a really tragic situation, and I don't think it has simple causes. I had the privilege of being involved in some of the discussions with ministers Morneau and Philpott when the concept of the earmark transfers was bubbling. And I thought this was at least a step in the direction of turning the provinces loose and partnering with them all at once by saying, here's an area of priority we all agree on. Can we work together on this in a more unified way? And the federation is maddening. We put the funk and dysfunctional when it comes to the federation of provinces and territories in this country. It just all began to melt away. I don't know the gory details, but I do know that right now we're in another area of crisis. But that leads me to say it's not only a crisis of healthcare delivery. This is a social system issue. This is unemployment, inability to afford a house, inability to have a sense of a future. And if we fray the social services fabric and we fray the economy, then you get a whole generation of young people who just don't have the supports they need. Add the stress of screens. We know they can be harmful to youth. Add all the social pressures of social media, the craziness, the sort of crazed consumption engendered by the exposure to all the influencers. It's a miracle any of us are mentally healthy of any age. So I don't have an easy answer here, but I think we need a multi-sectoral strategy, not just a health care strategy to begin to deal with this crisis in Canada.
Mr. Dale?
Well, Ontario is home to one of the world's leading cancer care systems. Cancer Care Ontario, now housed in Ontario Health. And the Mental Health Center of Excellence was founded in a statute about 4 or 5 years ago, just on the eve of the pandemic. And where there is a huge opportunity, the debate over what happened to the transfer aside for a minute, is to create a truly programmatic approach to the treatment side, moving into prevention for mental health. And that's something that can be done today with elbow grease and hard work here in the province of Ontario. So it's a great example of, I'm confident that the resources that the transfer would have enabled would be incredibly valuable, but we can do better with what we've got and get more care to people and prevent some of this from happening in the first instance with replicating that provincial program style model for mental health services.
Thank you. Ambassador Bennett, I'm going to ask if you want to comment, but we can move on to the next topic.
Well, I would like to say that people expressed concerns that the mental health transfer wasn't getting to the community, and therefore what is exciting is the youth mental health fund, when 2/3 of mental illness presents before the age of 25, that what we're seeing with integrated youth services in now 13 jurisdictions, which are what integrated care. So it's not only mental health services and addiction services and primary care, but housing, education, and labor in these hubs in Ontario, or huddles, or the Foundry in BC. And the fact that everybody is excited about this evidence-based approach for young people 12 to 25, and that is actually getting better results and saving money. And so there are really good things happening, but I think that it just is that and the 500 million over 5 years that was put last year into that youth mental health fund, I think is doing good things, whether it's CAMH or whether it's Kids Help Phone. The money is getting to mental health, but we know we can't really separate the mind and the body. And I'm excited by what UHN is doing with prescribable housing. You know, that we actually need to be able to um, treat the whole person in the community, and I think that we will see success, because these kids are running. They're the board. The people with lived experience are actually hired to work in these centers, and I think it's really one of the really great, exciting things going on now in Canada.
Thank you. Before I move on to the next topic, I do want to ask you one more question, Ambassador Bennett, and I do want Mr. Dale to also view on this. What would it take for hospitals to systematically leverage patient experiences, or lived experiences, as you said, not just as feedback, but as evidence to push for a substantive health policy reform? So in both of your views, and Dr. Naylor, feel free to weigh in, how can hospitals position lived experience as a political force, not just a clinical one, as we do so today? Ambassador Bennett?
I think Anthony should answer this. I think it's probably out of my bailiwick. I think that, I think patient voices has been very, very important in various ways, but up till now, it's been in sort of disease groups. And so to actually, and that's the reason I think family doctors are going to be the ones that actually transform a lot of this. But I think Anthony should answer the question properly, not me.
On to you, Mr. Dale.
It's a very good question and a very important one, because if not for this, what are we here for, right? The pandemic was an extremely disruptive experience, to say the least, and a lot of hospital-based kind of institutional memory and muscle did atrophy because of the length of the emergency. But every hospital will have patient and caregiver advisory councils that are central to decision-making in their organization. The OHA has also relaunched a comprehensive patient experience survey tool using digital platforms, and the adoption across the sector has been incredibly enthusiastic. So we're now equipped with more data and more information in real time about the patient experience in our hospitals than we ever have been before. So I feel like post-pandemic, we're in a better place to relaunch some more future-oriented thinking about the very question you've asked. So thank you.
Amazing. I do want to move on to our third topic, especially because I want Dr. Naylor's thoughts on this. It's my favorite topic. Is healthcare in a constant state of reorganization? So,
Disorganization.
all right, we beg to differ. So I'm 28 and I've already lived through two major reforms in our healthcare system here in Ontario. The
Imagine
Ontario,
what it's like when you're 55.
exactly, that's why I bring it up. So, just in my ripe old age, I've seen the Ontario Health, the LINS. I've heard there's something called the Health Links before that. I don't know how many other versions of this existed before. But why do we do this? What is the reason? Is it legacy building? Is there a method to the madness? Do these restructurings even produce better patient outcomes? And I do know that a lot of the healthcare workers in these systems have no idea what the names of these restructurings are. Some call them still the LINs, others haven't caught on to the Ontario Health. There's Ontario Health at Home. It's all very confusing. So hopefully you can illuminate some sense to the madness. Dr. Taylor.
I can't bring any sense to the madness, I'm afraid. And I'm older than 55, so I've seen even more of this, and a lot of it really up close and been part of some of it. My view is it's sort of the great and typical Canadian dodge. The country, I hope, has been jarred by this terrible set of developments south of the border into a new state of alertness about the need to innovate systemically and to get some real change afoot in multiple areas of the Canadian project. But the reason why I think a lot of this stuff goes nowhere and looks like sort of a circus movement is because it never grapples with the real issues of structural reform. And without structural reform, you can't get accountability. You can't get accountability with the current governance. It's all centralized, as Anthony's been saying. And you disempower the people who could be held accountable and feel accountable day in and day out. And the other problem here is governance in general. You need these governing bodies for whatever integrated systems are set up to be not only prominent citizens, which is what happens in hospitals overwhelmingly, I think Anthony would agree, but more representative. I'm not saying you have a bunch of grievors come to bring their axes to grind at the boardroom table, but having served on multiple hospital boards, it was interesting. The same people I used to ask for money when I was president of the University of Toronto. Not too many people who didn't have deep pockets and big CVs and big jobs. So I'd like to see more broad community representation and governance while keeping all those great people at the table to donate and to provide their business wisdom and lived experience as well. So I think we'll never get away from this, rat on a treadmill routine, on a flywheel routine. Thinking back to my beloved Eric, the rat I had as a pet as a child. We'll never get away from it until we actually do something very un-Canadian. We say we have to break some things here. We have to upset some people and do some things that they won't like to change the system fundamentally. And as politicians, we have to let go a bit and have this system be accountable to the people it cares for and live and die more by that kind of direct feedback loop as to how patients feel and families feel about the system and how it cares for them and supports them. Absent that, you're going to get the politicization and this random motion and pseudo reform that we've had for as long as I've been interested in health policy, which is now going on almost 40 years.
Thank you. Mr. Dale?
So Canada, when it talks integration, it really only talks about governance integration. So the rest of the country, every other province has created regional health authorities where the state appoints the governors to the health system. And in some cases, those health authorities don't even exist now. And what Santujan was saying at the very beginning is absolutely true. In those provinces, you're actually seeing the disappearance of the delineation of responsibility between political leadership and health system management. Look at Alberta as an extraordinary outlier if you want more and more evidence. And that's really the lesson of Ontario, which does still have independent governance, which is an incredibly important asset to our healthcare system. We're the highest performing province when it comes to hospital efficiency and on many quality metrics for hospital inpatient care. And independent governance, voluntary governance by local leaders and professionals and experts is a key factor in the performance of that health system. But until we get beyond the question of who's in control, which is the purpose of this panel debate about politics, and get to the creation of true systems, we'll be stuck in the same cycle.
Thank you. Ambassador Bennett, do you have any thoughts on this?
Well, I think it is about learning health systems, and it is about some sort of real change. And here in Denmark, the health agency has really buckling down, like Dr. Naylor said, from hospital to family doctors to community, and are really going to try and make that work. It's interesting that the head of the health agency here used to run the health system for an island, Bornholm. And I know when I was Minister of State for Public Health, that I found that the places that were sort of islands or peninsulas where you would actually, I remember in Owen Sound, it was the president of the Medical Association, the chief of staff of the hospital president, and the medical officer of health all presented to me together. And I think we've lost our way in the segregation, and then I think everybody's saying what people are talking about integration isn't really integrated. But I was thinking about this question that I remember sitting at a hospital board meeting once and saying to Michael Decter, has anybody mentioned the word patient once? And and I and so I just think that having people with lived and living experience really infiltrating where the decisions are being taken would be a really nice idea.
Thank you. Now we're moving on to our final topic, alarming trends down south, lessons for Canada. And so I'm sure we can talk about the elephant in the room, what's happening down in the United States. Once upon a time, we enjoyed comparing ourselves to them. We had a wonderful healthcare system. Their healthcare system was a mess. But now their choices are going to shape our reality. So the recent killing of United Healthcare CEO, and by the way, we're not going to be talking about this, but I do want to talk about this specific incident, was shocking. But what followed after that killing was even more revealing, a wave of public reaction that ranged from condemnation to vocal, loud support. So I'm going to quote a sociologist, Durkheim. He once suggested acts of deviance can emerge when society fails to adapt. They reveal cracks in our system. So in this case, it wasn't just about one man. It was a reflection of growing frustration with a model of care driven by profit and denial, and now with the current administration, politics. So my first question to all the panelists is, do you feel like administrators in Canada today, healthcare administrators, are giving up their agency to tech companies, consultants, private equity firms, and other entities who may not have patient care in their best interests? Dr. Naylor?
The short answer to that question is I don't know, because I don't know enough about who's doing what, but I am pretty suspicious of any generalization that assumes that what happens in the US happens in Canada. We've seen in multiple nations that electorates have spun away from Trumpism. That's happened now in, I think, 3 elections with some unexpected outcomes. Certainly ours was also unexpected. And so I think in many countries, there's actually a pretty strong backlash against that kind of sense of extremism. So I'm quietly confident that while we do have culture wars afoot, and we are going to have to beard some of these dragons here in Canada, that we will probably follow a more centrist and sensible route. The other point I'd make on this is that the US is uniquely out of control in healthcare. The costs are driving the huge federal indebtedness in the US. Trump's budget cuts taxes, but also cuts access to healthcare for millions of Americans. So you're going to have this worsening of the current situation and more anger, even as costs continue to spiral up. So, and the debt grows, which is, the US is the most indebted of major OECD countries on a per capita basis. Craziness. So I look at all this and I think with sadness, because the damage being done to US health research is very worrisome for the world. It's not something, there's no schadenfreude here. It's upset at what's going on, both for patients in the population and also for colleagues in research. But I think it's uniquely bad. I don't think it's going to transplant in a meaningful way. And I think I would just say maybe this will stop us from that bad Canadian habit of comparing ourselves favorably to the US and ignoring our own problems. If Canadian health policy people had spent a little less time gloating about our AirSat superiority and spent more time looking at the Commonwealth rankings that consistently showed us near the bottom for at least a decade, then maybe we would have concentrated more on fixing our system by looking at other countries where things work and importing what works from there. We might even have looked in the country, across the country, and borrowed things from other jurisdictions. In the 2015 report, we called this the NIH syndrome. That isn't National Institutes of Health. It's not invented here. Canadians just don't seem to want to use anything that was invented in another province. So we scaled some of the innovation domestically and borrowed from the best of other countries, including those US IDSs, integrated delivery systems. We'd be better off. So I don't spend a lot of time worrying about the US, except I worry about the damage being done to colleagues and to the public.
Thank you. Mr. Dale?
So what's really on my mind right now is, you know, our economy as a country and as a province is under direct assault by a country that we trusted and believed was our ally for as long as I've been alive. And, you know, with one sort of stroke of the pen, that's turned out to be untrue. And, you know, when I graduated from my school, the first free trade agreement had just been signed. So I don't know what life is like without this kind of economic relationship. But the reason that's relevant to today's discussion is it's economic growth that fuels prosperity, that makes high quality health services possible in the first place. So in addition to a massive demographic challenge that I've described, we now have a threat to our prosperity that is real. And what I hope happens is, building on what David has just said, that this is a true crisis. And who knows how it ends in the short term or the medium term, but we know that things in this country, in this province, are forever changed. And we've seen the country come together very quickly, provinces, territories, and the federal government. The opposition leaders nationally have come together in ways that I haven't seen before. So why don't we build on that and the momentum and start embracing the need for change in our major public services urgently? That's what I hope comes out of this, this situation from the United States.
Thank you. And Ambassador Bennett?
Just to go unpack some of what the questions were around industry or commercial interests. I mean, I think that we ended up with a situation of vendor-driven solutions that didn't talk to one another, and particularly in terms of e-health, and we do need some sort of coordination, so that, I mean, when you can get an ultrasound across University Avenue. I understand that's better now, but I do think that we took a long time to embrace some of the things that could be offered. And I went to the doctor when I was home at Easter. She asked if she could use her app. After I'd given my history, she had the subjective objective assessment plan all on the screen in front of her. We just had to change one thing, and she put it in my chart. So AI and some of the solutions are going to be hugely important in terms of how we do doctors do what they need to do, and all other professionals can do what they need to do. But I also think that we misunderstand that the Mayo Clinic, Kaiser Permanente, those are nonprofit organizations. In the early days, it was the Veterans Administration that had the first real electronic record that actually then dealt with the biggest problem, which is forgetfulness, and that we actually have things that we can learn. But what Dr. Naylor pointed out, which upset me so much, is we did think we were so good for so long, until you look at, when you're compared to the other systems around the world, Canadians would be ashamed. And so we've got to compare ourselves to other places, and we have to steal ideas that are working other places. And I think it was Etzioni who said that, Monique Bejean and I used to talk a lot, and she'd say that we are a country of pilot projects. Etzioni said, we should stop calling them pilot projects, call them experiments. And if try 5 things, and if 2 work and 3 don't, then let's move to the thing that worked. And I just think that we are um, risk averse, And I think it goes back to what Anthony was saying at the beginning, that whether it's question period or whether it's some of that really gets in the way of trying something. And the Auditor General quite often would love departments to just say, we tried this and it didn't work, so nobody else has to try it again. But that will end up in question period. And so I think that is one of the areas where the politicization, I think, is really holding us back.
Amazing. So my final question to all the panelists, and I'm hoping for a yes, no, and a little bit of an explanation. I don't like maybes for this question, but I understand if you have to. Do you think in our current political climate, can we reassert healthcare again as part of the national identity project in Canada as things currently stand? What are your thoughts? Dr. Naylor?
No. That's a pretty simple no. This notion of using healthcare as an identity bolster has had the fixation with America as a comparator. And I think rather than thinking of this as an identity issue, we should be fixated on healthcare as a huge investment for a better future for all Canadians. So if you took the identity away, I'd be fine with it. But if we start tying our identity to healthcare, I worry we will fall back into this false dichotomy of, look how much better we are than the US. So it's a nuance, I know, but that's why it's a no. Otherwise, I'm sympathetic.
Thank you. Mr. Dale?
You know, if the meaning is can we take this moment and make change, I think the answer is yes. And I go back to what Alistair Roberts said in his book, let's focus on resilience and protecting what we've got, but move with real urgency and adapt. Adaptation is absolutely key, but it has to happen right now.
Thank you. And Ambassador Bennett?
Yeah, I think that we can lead on health as a human right. I think that when you hear our neighbor to the south saying they've got better health care than we do, when people are going bankrupt, including physicians, that we actually have to look around and say, what are we going to do exactly what Dr. Orbinski asked, to make sure that people get what they need when they need it, and but that the data will tell the tale. That when the gap on the outcomes for Indigenous people are as really unacceptable as they are, we need Canadians to see that as a value, that we want to close those gaps in terms of, or the suicide rate, as you mentioned, 11 times higher in Inuit men. We actually, as what should be our value system, is that these gaps are unacceptable in terms of outcomes, and but I and that we have a long way to go to make sure that that people aren't having to pay for their drugs or for so many things that in the cost containment years got taken out of hospitals, and therefore they just aren't really being paid by our um, our universal system anymore.
Thank you. There you have it. The titans of healthcare have said that there is hope for a brighter future here in Canada. And with that, I open it up to questions. Oh, we have our first question already. I want to pass the mic over to you, and you could just pass it along to other people.
So just building a bit on Dr. Bennett's comment about Indigenous folks' poor health outcomes. My brain first, when I heard Dr. Orbinski's comment about describing politics as who gets what, when and how, was about health equity. And health inequalities are costly. We all know that, or many of us know that. For instance, around health inequalities and stigma, discrimination, hate are bad for our health. It affects access to healthcare, it affects access to housing, education, jobs, all that kind of stuff. One example, for instance, is that for lesbian, gay, bi populations, hospitalizations are 2.5 times longer for cardiac, diabetes and cardiometabolic conditions in Canada. So that's at a cost of about $26,000 per admission for about 11 days, rather than $5 or 5 days and $11,000 for straight folks. And the LGBT folks are often years younger. Same kind of thing for trans folks, higher rates of chronic conditions and onsets at younger ages. And we've got problems here. And this is just for one of the populations that experience health inequalities. Dr. Bennett spoke about Indigenous folks, racialized folks also have a range of different health inequalities. I'm curious what you see as the opportunity right now to make a difference around this in this context that we're in. And what do you think would make a difference in helping to advance that?
Who do you want to take? Who do you want to?
Create local and regional integrated health systems that have the mandate and capability to address the population health needs in a neighborhood, in a town, across a particular community. I mean, that's the real answer: integration, integrated care.
Yeah, I would say that we also need to be training professionals in all of those marginalized groups that really are having unacceptable outcomes. So, you know, the Indigenous Physicians Association, I think, is really working hard, but we need the care to be culturally safe, and whether that's to us LGBTQIA plus, or whether it's the South Asian or all, we need to understand that the teams need to reflect the people that they're serving, and that means they can aspire to be a social worker, a doctor, or a nurse, and we've got to make it easier for those people to we always used to the, the the First Nations used to say that nobody went into healthcare because they all wanted to be lawyers because of land claims. We've got to get them being wannabe health providers again, and to be able to come back and work in their communities and be those role models for those kids that are brilliant. But you know, we also used to say that, you know, you can't fix TB if there's 17 people living in one house. So how do we actually deal with health, which we want more of, and healthcare to decrease the demand side? So it is social determinants, but it is also, as you say, hate is, or racism, or all of these things, and prejudice kill.
Can I ask a favor? If any of you have any influence about data systems, can you make sure that questions about sexual orientation, data about sexual orientation is gathered? Like, I was able to fill in a survey recently where I could out myself as trans, but I couldn't because I had a question about sex where it had male, female, other. I don't like being called other, but there wasn't an opportunity to say I'm not straight. And that means we have enormous blind spots, whether that's around patient experience, whether that's about what's actually going on around our health outcomes, whether it's around pathways to access to care, whether people are being diagnosed later on. If you have any influence about that, can you please make a difference?
Sure, absolutely.
Thank you.
Same issue with race-based issues. You know, I think Canada prided itself on not collecting those data because, you know, we were less racist than our neighbors to the south, the same nonsense. But of course, what it created was blindness to the inequities that existed. So a great point about data. I just, as a footnote to what my colleague panelists have said, I just think the social determinants here are so important, because if we have to start trying to shorten length of stay for someone who is not a member of the straight community, as it were, if that's happening after the fact, we've missed the boat. So I do think a lot of this is upstream and probably needs research to understand the factors and the dynamics for it to be addressed ahead of time.
Thank you. Parmon?
Awesome. Thank you all so much for the great panel. I I think I followed the discussion, and it seemed like a common theme that each of you has a sense of urgency for changes in the healthcare system, and you agreed with each other at a lot of times. And to me, I'm not like entirely sure what that agreement's based on. I think I have two questions. The first one is on the question of urban versus rural distribution of healthcare, and in terms, especially in access to healthcare. Maybe Mr. Dale and Dr. Bennett, you guys can talk about this. What's the pros and cons of decentralization versus having a more bolstered, levers working towards supporting different communities, no matter the geography, in terms of enabling equitable access to care and across the country? And the second question is for Dr. Naylor and anybody else if they'd like. What lessons can we learn on the policies and politics surrounding training physicians? Because this has definitely been something that's been politicized, and especially in the licensing of physicians as well. Thank you.
Mr. Dale.
Great question on rural and urban. When the health, I'm obviously I know hospitals best, but I'm also very familiar with their urban and rural settings and how they work. In the 1990s, the government of Ontario restructured the hospital sector, consolidating the number of corporations from about 250 to around 150 at the end of the process. And that number has decreased further still to about 130 corporations across the province. But what happened is rural Ontario was kind of exempt from that process because those institutions are rightfully greatly valued by those communities. And I guess there was a sense that the benefit of that restructuring wouldn't be realized. But since then, successive governments have allowed drift to set in. And we now have a situation where you have a very large number of quite small hospitals serving rural and remote communities who are having real difficulty, especially with labor market shortage, maintaining their existing mandates. But many of them have changed and adapted quicker than any other part of the health system. And you have amazing partnerships and alliances that are effectively rural health hubs, for example, in many communities where you have far more kind of integrated thinking than you see in other parts of the province. The real issue is, again, about resilience versus adaptability. Is there an appetite in a community or in a region to allow more fundamental change where it's so clearly warranted, where the benefit of critical mass and scale, especially for hospital-based care, would definitely lift a broader population than the one that is holding on to that one institution? And that is one of the hardest and most explosive political questions in Ontario right now. And the pandemic environment and what happened exposed so many of those vulnerabilities. But I'm so proud of the rural and northern leadership in our province, in our hospital sector, because they're so devoted to delivering on their mandate despite the many challenges. But what we have to do is support them and allow change to happen, not hold on to something that was created a century ago in another economy, but allow thoughtful, considered change to serve the greater good. I hope that answers your question.
Dr. Naylor.
Thanks. It's interesting to think about where we've gone with national licensure. If you go back to about the 1880s, there was pressure from the profession and others to have a national licensing body. And there was actually, it's called the Canadian College of Physicians and Surgeons. That was the plan. And this, like so much else in healthcare and healthcare reform, these things bubble up. This one's particularly ancient. If you think about it, 140 years ago, it was bubbling. And now we're finally starting to do it. The interprovincial or interterritorial movement of physicians and other health professionals, if we generalize this, as I think we should, is never going to be massive. And there will still be a need for some oversight locally. So the license has to port, but it's not as though I'm going to be accountable to Ontario when I'm practicing in Nova Scotia. I need to have local governance and local oversight. So some of those things need to be ironed out for this to work. But the bottom line is simple. If you have the same number of doctors simply floating around back and forth, you really accomplish nothing. It's not as though any part of the country is so overburdened with excess medical human resources that we simply need to redistribute them. Like, we're short, as we are in many health professions. So, well, I think, easing interprovincial mobility is a rational thing to do. It's not going to solve the problems of the system. Turning to training and the educational system, it's pretty rigid, let's be clear. The accreditation processes mean that all of the undergraduate medical programs, for example, tend to be pretty similar. And you get divergence in the specialty programs because size matters here in terms of subspecialties particularly. This comes back to why you have to be careful about scale of hospitals. There's volume outcome relationships in many areas of medicine, particularly surgery. So what I think we have is a kind of implicit cooperative differentiation with some sites, some centers of education doing more subspecialties than others for reasons of volume and concentration of expertise. But here's the main problem. If I go back 30 years, we were talking about having a national health human resource strategy. It's 30 years later, we still don't have one. It's not clear we even have a provincial strategy. We suddenly decided to have 2 new medical schools in the GTA. Like, that was politics, I think, if I can be blunt. I don't think that that was carefully considered with a plan. Maybe a positive thing at the end of the day, but I don't see a planning horizon being put in place around health human resources that considers how, for example, a huge percentage of what family physicians do could be done by nurse practitioners with primary care training in a cooperative environment. And both sides, we know, would probably be happier. Why do we know that? And I'll close on this depressing note. Because 51 years ago, in the New England Journal of Medicine, a randomized trial was published from Canada of family physicians without a nurse practitioner, family physicians working with a nurse practitioner. The ones who had the nurse practitioner could delegate about 70% of their work, concentrate on the highest needs patients. The patients were happy, the docs were happy, the NPs were over the moon. And so clear endorsement in a randomized trial of this being a useful model. When the proposal was made to implement it, it foundered on opposition from organized medicine about how people would be paid and who would bill for the nurse practitioner service in this pushcart vendor model, and the government's cowardice. So, politics again, been around for a long time. It's a devil that we have to tame.
Thank you.
But I think that, as you say, organized medicine fought against that. I can remember landing in Nova Scotia, and one of the leading doctors had 2 nurse practitioners assigned to his practice, and they were sitting at home because he was worried about litigation or something. Like, it's been really hard and uneven across, whether it's midwives or whether it's in paramedics. It's been so uneven in terms of what the provinces and territories have felt comfortable doing or licensing. I think the national licensure piece is so exciting, and it's mainly because of COVID, because of virtual care, because all of a sudden you had the opportunity. Indigenous physicians wanted to be able to go and help in across some artificial boundary, that francophones could be helped, post-operative care, all of these things where people go to a big center for their surgery. They should be able to have follow-up care back in their hometown in a different province, and also university students and their their therapist or their psychologist should be. And so I think Will Falk's paper on care is care was really important. But I think that um, as we look at this big country, whether it's Lloydminster or whether it's Hull and Ottawa, people just don't think it makes any sense. And so I think we'll get there, and I think that it's and I think it's been very exciting to see the doctors finally really embrace the team-based approach, and the nurses as well. This is I think some of the the Health Human Resources conversations over the last few years have given me some hope.
Thank you. Question over there.
To begin with, a most excellent panel by all three of you, including the moderation, posing the questions erudite, sensitive, eliciting the information. My brief comment question is based on the power in politics, how transactional and short term. I spent about 6 months in Zimbabwe in the 90s, and the health system worked marvelously before Mugabe destroyed everything. You had the local shamans, you had what they call the white doctors, and the villages. It was all locally based, trust based. The polity is based on the health of what we call our public civics. And yes, there is a crisis, and the solution there, it is so difficult. And if I were to suggest, I mean, it's going to be very, very long term. It's a question of our political leadership class to understand that there needs to be ongoing delegation, that Parliament is elected for maybe 3-4 years, and then there's an election. Healthcare is in a crisis. It's been in a crisis for many, many years. And there's not one solution, but there is an attitude. And I believe our moderator made a comment with Durkheim and Omi. That is becoming so trenchant now, absolute despair. And the word I loathe the most is affordable housing, an oxymoron. Housing is housing is housing. Land and property is inelastic. It's a question of how you are going to create and build. Analogous to our healthcare system. What are you going to do? How are you going to do it? And you need to justify and you need to empower those that have access to our public funds to do the least harm. Thank you.
Thank you. We have a question at the back, and then we have one at the front. And I think that would be it for questions as we're approaching time. And it's almost 11 p.m., Ambassador Bennett in Denmark, and we're so very grateful that you're on the line here still with us.
They're still celebrating their win over Canada the other day. The Danes.
Yeah, no, that was not good.
Wonderful panel. Thank you very much for an insightful discussion. I think it's apparent that politicization is inherent to healthcare in this day and age. So the question for me becomes, who are the people making decisions for healthcare in politics? And to what extent, what does that mean for Canada in terms of reforming or improving the current system within politics so that we are making the right decision of healthcare? The reason why I'm asking this question, there are two antidotes. One is, if you look at Cuba, Black Swan, centralized healthcare, despite very limited resources, they were able to boost their healthcare metrics and overall healthcare outcome to about the same extent to the US. On the other hand, US as a foil, we typically view them as a more laissez-faire, more decentralized healthcare system. But more recently, in my space, we're working on early cancer detection test. And there's a recent legal ruling that said the FDA was trying to acquire and manage a system known as a laboratory developed test route, whereas a centralized route, all the blood tests goes to a single lab that's accredited, and you get results. That's a fast track route to launch new novel diagnostics and preventative measures for patients. FDA wanted to better regulate that, to have it under its own arm, so it tried to absorb that. But however, recent legal ruling has ruled that out, which means that FDA cannot acquire that, and that system exists. That's actually a major decision that happened in March that essentially fundamentally transforms the whole diagnostic landscape in the US from a more distributed, decentralized one to one that supports a centralized system. So two completely different political systems, but in both cases, we can see the influence of politics influencing healthcare. So what does that mean for Canada, and how can we learn from these lessons to improve our own political system in addressing better healthcare?
Dr. Naylor, I think that's for you.
Again, I'm going to be unfortunately direct. I don't think there's a great deal to be learned from Cuba or the US in that respect. You have incredibly strange decision-making happening in the US, and like monkeys in Shakespeare, every once in a while they get something right. but most of the time it will just be an unmitigated problem. So I'm not finding anything that's happening there to be very edifying. And then on the other side of the coin, Cuba actually did remarkably well in the pandemic as another example. But how do we generalize that to Canada? And I think the short answer is we don't. My plea would be to not look at these outlying situations where the analogies are limited as a totality. Look for those things that have worked wherever we can find them, ideally nations that are closer to our circumstances to improve the generalizability to our context. And then rather than adopt them, adapt them to what we have in Canada, and look widely and find the best plans and policies wherever we can pick them up. But be a little careful about those two jurisdictions, which are not very generalizable to what we have here. That's where. On RFK, my mother is calling to me from heaven. If you can't say something nice, don't say anything at all. I'm not sure that's the right person for making any decisions about healthcare. And this is the leader of Health and Human Services, one of the most influential people, on health issues in that country and in the world. Rob Califf, the former FDA commissioner, colleague we published together years ago, was scathing about RFK's abandonment of that bully pulpit. So, what we learned from that is just wrong people in the wrong times with the wrong powers can do harm. What we learned from Canada is that good people with good intentions, but a lack of political will, can also do harm not through any malign intent, but through benign neglect.
Yep.
Thank you for the panel. So it was mentioned during the panel that we have very much not grappled with the fundamental problems, but rather tinkered or tried to adapt around the edges. What I heard from Dr. Naylor was also that a few times this element of bringing physicians into the sort of the rest of the house within the team, and you mentioned that there were challenges around arbitration or other just fundamental power structures. So the question is, what levers do we have to finally bring physicians into the fold?
I think it's for all three of you.
I'm going to pass to the president of the Imperial Hospital.
Well, look, these aren't kind of abstract policy questions. These are collective bargaining rights of almost 40,000 Ontario physicians and their colleagues across different provinces. So hopefully the OMA understands the gravity of the situation that lies ahead from a capacity and capability point of view. That's how I think of what's coming fundamentally. Will we have enough health services capacity and capability to meet the needs of the people of Ontario into the future? The OMA has a new strategic plan, and I think that they are struggling to, in these early days, to live up to its full potential, which aspires to put the health system first alongside its collective bargaining responsibilities. So in our society, it would be a very political thing to do to overturn those systems of collective bargaining rights, and that's the last thing I would suggest. It's a negotiation, but there really needs to be some urgency here and understanding about what could happen if the public interest over the long run is to be pursued.
I'm going to be mischievous and say, is it appropriate to give collective bargaining rights to a guild of small business people? And is this not actually nothing to do with the collective bargaining rights of employees who have a direct employer who can hire and fire them? But in fact, most of these individuals are self-employed professionals. And it seems to me that it's one thing to say that you have some form of mediation and conciliation, and that you don't want docs on strike, obviously, and you value them and you want the pool to grow and be happy. But it seems to me that, this question of the conditions of work and the lines of accountability is something that does not belong at the bargaining table with its strange dynamics. As I said, I did mediation in Alberta and Ontario. I know what the bargaining table is like from that experience. I don't think it's changed much. It's not a place where you do great policy making. And the OMA has the difficult responsibility of getting a global budget increase and passing it out to all the hungry specialties and the family physicians. You can imagine what that's like. The internal bargaining is probably uglier than anything you see with government and the medical association. So I'm sympathetic, and I've been in the middle of this stuff, worked closely with the OMA in years past, and the CMA, but I worry that arbitration cannot create a bar to structural reform in healthcare, and I'm concerned that in its current form it will. Last on, this is some God-given right. There was no binding arbitration in this country for physicians a decade ago, 15 years ago at most. In Ontario, it's a relatively recent development. And the question is not whether it's therefore sacrosanct, but whether it needs modification and reconsideration so that it doesn't become a barrier to healthcare reform. We also need to think about the extent to which this allocation of money across the different specialty groups is vested with the association. On the one hand, no one should ever get between docs and their money in these situations. It's a dangerous sport. But there has to be some logic model that says, by the way, the public interest says we need to give family doctors more than ophthalmologists. And I like ophthalmologists, but maybe that's what we need to do right now. So I'm concerned about this development. When asked about it, I said, do it once to clear the bad baggage from 2014-15 when we couldn't get a deal. Let's just settle things down. And I said specifically, don't do it indefinitely, and I haven't changed my mind.
I would just like to say I had one very long year on the OMA board. I was quite surprised. David's picking on ophthalmologists, but that was at the time when they were moving from a procedure that had to be stitched and to the suction thing, and it was the difference between what the time it took and like it was and the number of patients they could see, but the price had to stay the same even though the technology had really moved them along. And I remember everybody just thinking this doesn't make any sense. And so when you go and you see that what we now call brick bungalow um, solo practitioners, we know, and maybe David would correct me, but years ago there was data that showed that the most sued or reported to the college were solo practitioners. Less if you were in a group, less if you were in a group attached to a hospital, less if you were attached to a teaching hospital. I don't know why those people aren't paying more medical malpractice insurance for being a solo practitioner in it. And we also know that the med students want to work on teams. Like they want to come out and work on teams. So we actually have to figure other ways of remunerating and being able to just say it's over. And even here in Denmark, people are quite clear that it'd be very hard to get rid of fee for service. But I I I I never understood it. I thought if I wanted to talk about money, I would have been an accountant.
All right, we have room for one last question.
Thank you. So you guys talked about the whole family doctor thing. We want to sort of rescale issues that specialists would focus on and kind of reduce the burden on them onto family doctors. But that kind of sparks the question for me is, aren't we in a shortage of family doctors? So I just creatively thought of a few ideas, and I just wanted to wonder why they haven't been implemented yet. Are they in the making?
One would be sort of just overall reducing the focus on treatment and more on prevention. So, for example, why instead of needing to rescale an issue from one type of doctor to another type of doctor, why can't we even reduce the need for this to be an issue from the beginning? For example, like why can't we have, I don't know, assemblies, posters in elementary schools and high schools telling people to fix their posture? That'll fix so many different bone issues that are then causing issues in health later on. This will reduce the load on family doctors, the minimal amount of family doctors that we even have. That's one idea. I just want to know why that hasn't been done or why that can be done or whatever. My other question is, I've heard a lot of chatter about immigration and its relation to the job market, and I feel like even healthcare plays a large role in that. Why are people who were doctors in one place have to settle for jobs that they haven't dedicated their whole lives to, unlike, for example, the medical field? Why can't we work on that specific policy that if you were a doctor in a different country, it shouldn't take you years of studying for exams and maybe even your whole degree being dismissed for you to be able to literally go back to doing the job you were previously doing in a different country, instead serving Canadians? So I know that was a long question, just to rephrase. One of them was, why can't we have more education to even prevent the severe emphasis on treatment? And my other question is, can we refocus policies surrounding immigration and qualification?
Yeah, no, those are two very, very important questions. I think they are at the forefront of today's discussion. So health promotion and reskilling. I'm going to let our panelists answer, but I'm actually very curious to see what Mr. Dale thinks about reskilling and why that's, not talked about more heavily in today's healthcare landscape.
I'm probably alone in this room in thinking that we've actually made some progress, at least over the short term, when it comes to the health human resources challenges facing the country and the province. We've had material increases in hospital staff, for example. Our headcount is now 300,000 employees. That's an increase of 35,000 pre-pandemic. There's all sorts of other kind of data that shows vacancy rates are dropping, but that's not your kind of core question. On the second point, the provincial government, and by virtue of this crisis with the United States and the concept of free trade and portability across provinces in terms of the labor market, we're seeing momentum now to address many of these kind of more foundational practice barriers that have existed for historic reasons that are kind of lost sometimes in the murky responsibilities of regulatory colleges. So that's a good example of some change starting to accelerate out of two crises now. And then on prevention, I couldn't agree more. I encourage you to go to our website and look at the study that we sponsored in partnership with the IHPME, the Dalalana School of Public Health, to look at the demographic and epidemiological challenges that this province will face. It faces already, but it will startle you at the magnitude of it. And one of our best weapons against this onslaught is prevention, making sure that people just don't get sick in the first instance. And if they do get sick, we actively manage their chronic disease in a far more effective way so that they never end up in an inpatient ward in a hospital, perhaps even palliative, because they didn't get care they needed at the right time of their lives. So this is, for me, I thought, leaving the pandemic aside, that things would quiet down and we'd be in for a calmer time in healthcare, but this challenge far eclipses the public health crisis that was the pandemic. So prevention's very strong primary care, integrated care, and I mean really a robust primary care, not doses for infections for the elderly and you call it a day. I mean like active management of primary care responsibilities to the fullest extent of the scope of practice of those practitioners, both physicians, nurse practitioners, nurses, and other professions, because it's our best defense against what's coming.
So is this in the works? Like, have we been thinking about outsourcing to the education system towards even the workforce? So this has been in the making, you're saying?
Well, public health has responsibility for that kind of education component. And we all know that the best way to get people to understand their health and maybe change the way they're living is by a one-on-one engagement with someone they trust, a healthcare professional or another kind of professional with the kind of skills and knowledge to help them. So to me, that's where the real money lies. And we have reasonably well-organized primary care in Ontario through the legacy of family health teams. But for some inexplicable reason, about 10, 15 years ago, we just decided, well, we've got yeah, and meanwhile, we've got millions of people who need to be rostered. And so I think there's a good debate to be had, as Dr. Naylor said, about the kind of model that the province seems to be contemplating, but I like the ambition. Because for the first time, we've seen an explicit political commitment to roster 2 million people in just really half a decade. And they've set out targets, we'll either achieve it or we won't. And I think hats off to the government, to Premier Ford and Minister Jones for doing that, because that is an ambitious thing to try. And I hope we succeed.
Just to say on this front that there is such a dearth of care at the moment that it's pretty hard to pivot the system back to prevention. The second challenge is that you've got to think about pre-primary prevention, which is more in the social determinants, primary prevention, which is in the hands of health professionals, and secondary prevention, which is what you do after a disease state has manifested itself. And they each have different zones of responsibility. Some of them are in the social system, education. We should be doing a lot more in health education in school systems right from the get-go, along with critical thinking, as Carolyn Bennett mentioned. On the primary prevention, bolstering primary care is so important for that, because that doesn't need to see a specialist 90% of the time, and the person they trust most will be the family doc. But a lot of the secondary prevention falls to specialists because they see the patient with a given disease condition. So to make this work, and I agree, we need to do it a lot better. We need a spectrum approach. The last thing I'll say is the evidence base is actually moderate, not great. A lot of primary prevention is actually not very cost effective, believe it or not. We need better tools. And there's something very exciting happening in the UK right now. Sir John Bell, Canadian, who's been there forever, is leading or got going a very large scale study with millions of subjects designed to address different strategies for treating and preventing chronic disease in that population. They have the same demographics and worries as us. So instead of just sitting back and using the evidence that percolates through or doing small studies, they're doing a massive population scale study to see what impact they can have over the medium term, not very long term. So I'm really excited to see what they come up with. That could be transformative for all industrialized nations to really give us very effective guidelines as to how to intervene and how to prevent some of these chronic diseases earlier in life, say 30s and 40s. So that's a very positive development. So fingers crossed, but I think it's a really important issue to raise.
This is so important because it's not enough just to think of it as throwing people at the problem.
No, and I think, David, when you were saying about the education systems, like the whole issue of health literacy, and particularly, I think where Canada's leading the world on mental health literacy with Dr. Kuchar and Dr. Way from the University of Alberta, they were over here 2 weeks ago, and the idea that you can build mental health literacy into the curriculum, and and you can start to understand what are normal emotions, what is pathology. It's a really exciting, I think, that we can help one another identify they're not okay, help their friends, guide them to care. It's going to be, we've even got the handbook for mental health literacy for parliamentarians. And but it really is that if your grandma dies, that's not a depression, that's normal grief. If you are studying for an exam, that's stressful, that's not an anxiety state. And we've got to help people use the system wisely. And I think it is going to be about getting back to letting people know about their bodies, about parenting, about there's infant checks regardless of who you are. You still get checked on after you go home from the hospital or have your baby. Like, taking the public health nurses out of the schools is a false economy. I mean, that's where we can start to really build citizens who actually are prepared to look after themselves and in that health promotion, disease prevention.
All right, thank you. A round of applause for all our panelists. Thank you again, Ambassador Bennett, Dr. Naylor, and Mr. Dale for attending this. The Massey Health Administration Dialogues is in its second year running, where we talk about some of the biggest topics facing healthcare annually. We hope to see you again next year. And thank you once again for everybody in the Massey community and abroad. I see 4 of my fellow classmates here as well to attend this dialogue. And hopefully you guys go on and really question and interrogate some of these big themes, and even in your own leadership roles, really bring forth and unpack how politics play a role in your day-to-day lives. Thank you.